Glaucoma diagnosis and management is incomplete without gonioscopy. This simple test gives tremendous amount of information, and even a simple primary open angle glaucoma cannot be diagnosed without looking at the angle. There are different types of gonio lenses like Koppe's lens, Barkan's lens, Swan-Jacob or Richardson for direct gonioscopy, and a single 2-mirror, 3-mirror or 4-mirror for indirect gonioscopy. Okay, yeah, I think that's only better. Gonioscopy. This is how a Koppe's lens looks like, and that is used for gonioscopy in supine position, especially for children under general anesthesia. Change to the slanting position by moving this knob, and then the concave part of the lens is filled with saline and is inserted onto the eye. The angle is then examined directly under the microscopic view that you can see. You can put saline on. The most commonly used lens for indirect gonioscopy is 4-mirror that has the contact surface smaller than the corneal diameter and is of same shape, whereas the 2-mirror lens has a concave surface and is larger than the corneal diameter. To perform gonioscopy, position the patient appropriately on slit lamp, examine the ocular surface and note the condition of the optic nerve with undilated pupil. Explain the procedure to the patient and instill the topical anesthetic agent. For a 2-mirror lens, use a topical anesthetic agent. Video is missing. Is it audible? Swan-Jacob or Richardson for direct gonioscopy, and a single 2-mirror, 3-mirror or 4-mirror for indirect gonioscopy. This is how a Koppe's lens looks like, and that is used for gonioscopy in supine position, especially for children under general anesthesia. The microscope position is changed to the slanting position by moving this knob, and then the concave part of the lens is filled with saline and is inserted onto the eye. The angle is then examined directly under the microscope. If you're not able to hear, I can audio it. So I think we saw how a 2-mirror is. Okay, I'll go ahead in interest of time because we have seen this. You can close the audio, please. Okay. So now you watch the corneal surface so that you know that you're not doing any harm to the patient by doing gonioscopy. The surface is all right. You use a topical anesthesia, and then the patient is ready for taking it. Now this is a 2-mirror where you need a coupling agent. So you ask the patient to look down, fix the lens over it. Since it is a coupling media, it holds very well. Then you can look at the angle, increase the magnification. In case of a 4-mirror, it is very simple. You just hold the lens in front of the eye. You ensure that the tear film is uniform between the lens and the cornea. That is when you start seeing the angle, and then you can go to the angles. Now, this is how you look at the angle, but the ideal technique that you should use is the room light has to be off and the beam has to be small so as to understand what is the angle in the physiological stage or scotopic state. And after that, you increase the light, because if you don't reduce the light, your angle would appear artificially open. To take the video, I had increased the light. So this is the correct technique that is actually you should follow. Look at all the angles under those conditions. Now these are all different examples of gonio angles, which I will explain. Now these are the structures that you can see. So this is an oblique illumination in the inferior angle that you see. To localize the Schwalbe's line, the technique that you use is called wedge technique. Now here you can see the two slit beams going on, and where the descemettes end, the beam collapses because the light can no longer go beyond that. So you start seeing a single slit. This is called corneal wedge sign to identify the Schwalbe's line, the anterior most structure. And if in case you're not able to see otherwise, so this is a quick technique. And then you see the structures like trabecular meshwork, scleral spur and ciliary body band. There are different angles which can have different type of pigmentation, so you have to be aware that even the normal angle can look different if the pigmentation level is different. This is where you can see the pigmentation anterior to Schwall base line, which can be an indicator of angle closure. So you can see the angle is opening on indentation here. So this is one of the PACS. You can see the patchy pigmentation of the trabecular meshwork. That is another sign of prior occlusion, which indicates that the patient would require intervention. These are the goniosynechia you can see in the inferior angle, suggestive of angle closure, primary angle closure or glaucoma. And here also you can see a synechia. This is again goniosynechia. So that is a classical example of primary angle closure. Now in this angle, you can see that once you see the convex iris surface, which is suggestive of the plateau iris syndrome. So you have a convexity near the angle and then there is a depression. This is called sine wave sign. So you will see all other signs of angle closure and along with that this sign which is suggestive of plateau iris. This is the blood in the angle after injury. Sometimes you can miss it. And this is the area where you can see the angle recession. You can see angle recession, widening of ciliary body band. These are black balls in the inferior angle, suggestive of old hyphema. So this is a trauma patient. And these are iridodialysis and cyclodialysis. This is how it looks like when you do gonioscopy. Both the things you can see in the same patient incidentally. Here you can see the silicone oil bubbles in the superior angle, which can indicate the cause of glaucoma in a patient who has undergone vitrectomy. So this is called inverse hypopyon. A foreign body, this is a glass foreign body in one of the patient who had a car accident and presented to us with the vitreous hemorrhage. So sent to me for gonioscopy and we found a foreign body there. This is the angle where you can see the blood vessels. This is neovascularization of the angle. These are broad PAS post uveitis or inflammatory situation where you can see the broad-based synechia in the angle. Sorry. It's okay, we don't want that. So this is an iris cyst that you can see on UBM that can also be picked up. This is a mass which can be detected on angle and can require further this thing. There is a Krukenberg spindle you can see which is visible on the slit lamp, and when you look at the angle you can see a classical concavity which is suggestive of PDS or pigment dispersion syndrome. That is again, you can see the pigmentation, increased pigmentation on the trabecular meshwork with concavity. This is a Sempolizi line and pseudo-exfoliation. Pseudo-exfoliation material can also be seen in the angle. This is a internal ostium, which you can see is patent post-trabeculectomy. When the post-trabeculectomy there is a failure of or the pressures increase, we tend to look at whether the internal ostium is patent. This is a closed internal ostium due to iris. That means you would require another surgery, and working on the external surface would not help. This is one of the express shunt tips that you can see on gonioscopy. So sometimes you can miss it if a small area is not looked at. So there's a steel implant express shunt that can be seen. So basically it is important to understand that how do you look at the angles, as I said, under dark room and then increasing the light. It's an important tool for diagnosis and management of glaucoma. And that is where I would end, because I think we will stop here. In interest of time, we have already lost time here.
Just so one thing I would like to say in the words of Ravi Thomas, that do 1,000 cases. Yes. And that's the only thing that you need to do. Rest of the things you can read from books. Just do 1,000 gonioscopies.